All right, it's going to ask you.
Perfect.
Great. All right, welcome everyone. Today we have Didde Thorsted with us. She's an experienced osteopath, physiotherapist, and naturopath with a special interest in paediatric care. She's based in Denmark. With over 25 years of experience, Didde has lectured extensively and founded several clinics and organisations related to paediatric health, including the Danish Pediatric Osteopaths Association and the Happy Baby Academy. Didde is coming to Australia in November to teach 2 courses in Melbourne. Welcome, Didde.
Thank you. Never been. That's going to be exciting.
Oh, really? You've never been to Australia?
No,
Fantastic.
it's my first time.
Well, that's fantastic. So you've been at the forefront of paediatric osteopathy for many years. Can you share what inspired you to focus on this field, particularly in infants? Does it have anything to do with having 4 kids and 2 grandchildren?
Well, yeah, that set me off,
Yeah.
obviously. But also training as a physio, I was so blessed that I was allowed to join the pediatric department in one of the big hospitals instead of doing my neurology with old people that we usually do. I had the blessing of joining the peds instead, and it was fantastic. So it's been like a passion of mine ever since I studied to be a physio, besides having children. And besides, struggling with normal issues where I was like, can anybody help with this, please? So, I mean, yeah, it's just always been a passion of me working with children. I think over the years, it just got bigger and bigger because before I also worked with women, but I think I came to that realization that if I change just the first years of life, I could actually set them off for having a much better body awareness, much better health in their bodies than if I just left them alone and tried to fix them when they were 24, 25. And also babies, they react instantly. When you fix something, they go, oh, this is nice. And they don't just go back to, I'm just going to watch my iPad. They use it. They really, mobilize their whole body as soon as they're free and movable. And it just inspired me so much because I was like, but if we give them that freedom to move already from when they're very small, well, we might not see as many problems along the way. So actually, I was like, I'm going to focus on this. And another thing was when I got into pediatrics, I was actually scared of the amount of knowledge I didn't have. I was actually going, oh my God, because I was trained as a physio and an osteo to treat adults. And we had a very brief pediatric course as well, but it wasn't very substantial. I mean, I went out there and I treated children, and going down this path, suddenly I realized, oh my God, I didn't know half the red flags. I didn't actually know the body I was treating because I didn't even knew the anatomy and the physiology, something that we really are proud of as osteopaths, anatomy, anatomy, anatomy. And I was like, yeah, anatomy, but it's different in babies. And nobody actually took the time to say, well, if you want to work with this, I think you should go home, sit down, have a very flat butt, and don't get up until you know your physiology, your anatomy, your neurology, your pathology, and developmental states in a baby. And then you can come back and treat them. And I think, I don't know if it's just here, but I think it's quite general for our profession that we're like, oh, we'll just treat these little children like they're small adults. It will be fine. We treat what we find. But the more I got into it, the more scared I got because we are working on the biggest thing in life. We're working on the most precious thing a parent have, their child. And we need to be humble and we need to be really well educated if we put our hands on people's gold. So realizing that, I suddenly saw, whoa, if I need to be good at this and I'm just working with children from 0 to 12, I really need to know the stages. I need to know the development. And it's vast when you look at a child from 0 to 12. So many things happen. So it's an ongoing study. I'm still, reading. I'm still dabbling around on the internet to try and find articles to explain even more. I'm still taking courses and educations, you know, trying to collect knowledge, to be more and more secure on. And the only thing I know is the more that I know, the less I know. That was my realization, and why I ended up with just doing pediatrics, because I was like, I'm not even doing teenagers, because as soon as the hormones kick in, wow, we have a totally new scenario. So for me, that was to be better at what I actually do and more safe.
Yeah, that's really interesting. I remember when I did my PED study, we were taught that osteopathy generally for babies is quite safe. The highest risk was that we would miss something, and that was, you know, a red flag or a developmental delay. And exactly what you were saying, like, it's really a part of our duty of care, isn't it, to have at least, you know, enough to know when things are out of our scope, when to refer, you know, what things to ask for in a good case history, for sure.
Yeah, because I really get sad when I hear my colleagues say, well, I just treat what I find. And I'm like, yeah, but are you sure you're even safe to treat? Do you find the signs of cardiovascular problems or neurological problems? And that makes me sad, because they should be caught up very early on. Sorry if I interrupted.
Sorry about that. We're back. So that's a very good point, that yes, to begin treating children, you definitely should do a little bit of background training, and probably not a little bit, and at least be aware of what you don't know.
Yeah, I agree.
What's it like in Denmark as an osteopath? What's the profession like over there? Is it big? Are you in hospitals? What's it like?
No, we're just in private practice, and we're still a new profession. We just got regulated 5 years ago, and it was finally like we had a 5-year transition period from not being regulated to being fully regulated, and that just happened last year. We were fully regulated and protected. So before that, you could just be, you know, a carpenter that just took a weekend course and said, well, now I'm an osteopath. With good hands. But now you need to have a health background, and you need to do your osteopathic training, and you need to be to have like a certification to treat. And we're all in private practice. We're still trying to get the doctors to recognize we're there. Most of us are physios to begin with, and just did osteopathy on top of our physio. So we have already been regulated, and the doctors know what we can do. So we have a foot in there, but it's still, they are still thinking about us like, oh my God, it's like they're chanting and you know, sound healing, and yeah. So we're still trying to get our footing, but we are recognized now on an equal ground as physios, chiropractors, doctors, nurses, and so on. And also I started this organization because I was so frightened that one day one extremely nice and sweet osteopath with the best intention might make a mistake and treat a child that shouldn't have been treated. So that was actually why I made the association. And we had quite a rumble, because people were actually very, very mad at me because I made this association, because they felt excluded, because I said, well, we need to have some sort of basic knowledge if we want to be a part of this, if we want to treat children. And people were frightened because they felt threatened on their economy. So they didn't really think about the effect it would have on the babies if they did something wrong. But if they were not allowed to treat children, or people would prefer to be treated by somebody that actually knew what they were doing, they felt that would threaten their business. So we are still struggling to get this association going. And now we managed to sort of have like at least a foot in with the Danish Osteopathic Society. So we're trying, instead of having it as a separate organization, trying to get like a specialization within the Danish Osteopathic Society. So hopefully that will be a fact over the next few years. That's at least what I pray for.
Well, you might meet a few advanced practice osteopaths who are titled from our Australian Osteopathic Association. There's a bit of paperwork involved, so some of us older osteos are still getting around to doing it and handing our paperwork in, but definitely I think it's an important process to go through, because it does help, I suppose, set the bar for what's required to be a pediatric osteopath for sure. So yes, good on you. That sounds like a lot of work.
Yeah, and we see it in the physios. They have specializations as well within within the pediatrics, within sports, within gynecology and obstetrics. So I think that will be the way for us as well, because we really need to have this extra knowledge if we want to work with these very vulnerable client groups, I think.
One of the other things that I was quite interested in learning about you, Didde, was that you had a lot to do with the national guidelines for tongue tie in Denmark. Can you tell us a bit more about that?
Yeah, I was invited as a part of the reference group. So they have a work group where one of my very good colleagues, a chiropractor named Charlotte, was in, and they did all the hard work, reading all the articles, all of this. And then the reference group were called in to give our word as well and say, what do we think? Where are we going? And of course, I would have wished that our voice had been heard more clearly, but I do think it was quite a pat on the shoulder to say you can come in and join us, because we were there equal to everybody else in the room, and it was very nice. I think the problem is when you do the national clinical guidelines, you use the PICO. That's a research method where you sort of like have the recipe and you say, well, we need 4 brown eggs, and if the egg is yellow or brown, white or whatever color, it's not included. So I do think a lot of actually research was not included because it did not exactly match the recipe. Yeah. So but I do think that it was, what I thought was nice about it was that before we were really split up in fractions: osteopaths, physios, breastfeeding consultant, doctors, doctors saying, oh, this doesn't exist, and other doctors says, oh yeah, it does really exist. And I do think it gave us a common ground to work from. We agreed on using the TAPI as like the lowest bar, so we all need to know how to use the TAPI if we work with children that are breastfeeding.
What's the TAPI?
And also the TAPI is a screening, a 4-point screening for tongue tie. It has 2 functional and 2 structural blocks, where you look at the tongue and the tongue function to see if there could be an issue when you have bad breastfeeding. So you have this whole breastfeeding block, how's breastfeeding going, and then you have this scoring tool that's been validated. So it's actually 4 blocks taking out of the Hazelbaker that has been validated and scored really well in reliability, and also when a lot of people test it, they sort of get the same results. So we all need to use that, and that's really nice, because then when I have a patient coming in that's seen the breastfeeding consultant and said, well, it's a TAPI 4, then I already know, okay, this child needs really a lot of help. And a lot of times if they score low, they will go directly to the ENT that does the incision of the tongue tie. And hopefully, because it wasn't not recommended to see an osteopath. It was just said that because it was a private practice and it cost money, that it was not something they would recommend for everybody. So that's actually very nice for us, because it didn't not recommend us. And I do think now, with the things changing around, before we were like, well, this is a structural problem, that's not for osteopaths. We can, do a bit about the symptoms, but the cause is not something we can work with. And with the study about the anatomy of the tongue tie showing that it was part of a fascia, that was a big surprise to everybody, I think, except body workers, because I was like, but of course it's a part of the fascia. What else should it be? Is the string just
Mm-hmm.
lying there on its own, not connected to anything?
Mm-hmm. Mm-hmm.
But what I was happy about was that it actually gave us common ground again in different professions to speaking the same language. So now we agree on it's a part of a fascia. And that actually opened up, I think, for osteopathy and other manual practices, that we can actually try and change something before doing an incision. So we work very closely together with breastfeeding consultants now. They send the babies to us if they suspect jaw issues or tension issues in the mouth floor, and we really get in there and do whatever we can and give parents home exercises, and we actually see a lot of change. And a lot of babies that were actually set up to have the incision is now not cut, because we actually improve function so much that they don't need the incision. So I do think tongue tie has really changed from being structural, we can only help with symptoms and we need to cut, to now we will see what can we do, better breastfeeding advice, getting all the tension solved. And if we still don't manage, then we can send them on to the ENT or the pediatric dentist or whatever to do an incision. And then we will follow up with neuromuscular rehabilitation to get that tongue moving, and breastfeeding again for having a better latch and technique. So I think it's harder now to really give good advice, and there's much more, let's wait and see, let's try this. Before it was like, no, sorry, can't do, you have to go to see the ENT. So I do think the national guidelines gave us common ground. It gave us a common field of expertise that everybody should have if they read them, the national guidelines. But I also think that it opened my eyes for how different we view the world. I know we have different glasses on, just person to person, but I was actually quite amazed, because I was like, but why don't we train the tongue before an incision? We do training every other part of the body before doing operations, and we try and see if we can not do operations by just training. And after an operation, we do training again, because we know how important it is. And we also take care of the scarring to not have scars that restrict our mobility. And I was like puzzled, why don't we do that when it comes to the tongue? And one of the pediatric doctors, he said, well, it's just because the babies know what to do. And I'm like, well, not the babies I see. I mean, not all of them. Some of them do. They're just like, oh, this is what I need to do. Okay, I just used my reflex. But a lot of them are still going, well, what is this? So it just didn't make sense to me. And I said, why? And he said, well, that's just because that's the way it is. So we also had that, I'm a doctor and you're not. So that was a bit disappointing. But I do think that even though his reply were like that, I do think he went home and thought, oh, yeah, well, I didn't really think about that. So.
I haven't heard of the TAPI. I'll have to go check that out. We use the Hazel Baker and a couple of others as well sometimes, but mostly what we do here is if it's in that grey zone. So if the function is not terrible but not brilliant, but somewhere in that grey zone of, well, will we snip it or not, then those patients are often sent off for osteo. There's always that time thing where you've got a mother who is really struggling with lots of pain and need it. The breastfeeding's at risk, really, and sometimes getting very prompt osteopathic care can be tricky. That's always a bit of an issue. But I think there's just so much to learn, isn't there, about the kind of work we can do with tongue ties, and it's been an ongoing thing for me to work out which babies I can, that I don't need to refer and which ones I do. And I've been learning a lot about it lately with the different types of attachment. We were going to talk about it, the inferior attachment of the tie and how far forward that sits, and whether there's, so with your experience of tongue tie, can you tell me more about what sort of ties do you see that you're just like, this one definitely needs to be snipped? Do you have an assessment tool that you really rely on and a score, or is it more of a a physical assessment of watching that baby move? Like, what do you do?
Well, actually, if I have like the Carrillo's type 1, where it's really attached to the gum, to the point of the tongue, usually the doctors do agree on it just needs to be fixed as quickly as possible. So that will be the very anterior, and that will score very low in the TAPI as well. So that will be below 5 points, and they will be referred very quickly on to ENTs. Where when they're just a little bit higher and they still have breastfeeding issues, we would have the IPCLCs come in and to do the breastfeeding consulting. And if nothing changes within 2 weeks, they would also go see the ENT. And so I think when I do the assessment, I always do the structural functional thing. I always do the TAPI because I need to do that. That's sort of an agreement we have now. And also I do functional testing. So I used to do the Hazel-Baker or the Martinelli's, just to see what else do I see, what functions do I miss. But the TAPI actually gives us like a starting point, and it's because those 4 points from the Hazel-Baker was the one that has the highest inter-rater reliability. So if I do it and everybody else do it, we almost see the same, or we see the same. Yeah. So that will tell me about a little bit about the function and a little bit about the structure. And then I do the testing of the body. What structures are in trouble here? Can that mimic a tongue tie? Can the tension from the body over the facial system, over the muscular system, mimic a tongue tie? So if it's not really structurally obvious, then I would go even more into this. I also have babies with type 1 that actually breastfeed. I don't know how, but they do. So, I mean, so before I was like, well, type 1 definitely needs it. But now it's actually much more of a functional problem for me. So I evaluate the structure, I evaluate the function, I look at the body, and I look at the symptom burden. So I look on what problems do we have? Do we have pain in mom? Do we have issues with baby, like reflux, like clicking, like swallowing too much air, all of this. And that whole puzzle put together will sort of direct me into where do I need to go? Do I see that a lot of bodily tension that I might suspect also is affecting this breastfeeding technique and might even mimic a restriction of the mouth floor? Or is a restriction of the mouth floor that might mimic a tongue tie?
So, do you notice a difference in what you feel through the body for a like an anterior versus a posterior tie?
I do see a little change, but usually most of them have this anterior glide where they're like a little bit of hyperextension. So most of them, even if it's the anterior, because when we look at the tongue up here and the mouth floor here, if the attachment is here, the anterior, then it will affect all of this, but especially the first part not coming over the gum, protecting mom's nipple. If we have it a little bit further back, well, then we might have a little protection and might have a little anterior movement, but we're still having a restriction of the things lying behind. So I think the further back the restrictions go and the deeper it goes, well, the more of tongue movement is restricted. But I do think that if we have the restriction of the anterior, it will also affect my ability to lift my mid and posterior tongue for the lifting and the mobility of the tongue. And also through this, we will have an effect on the jaw. And we know now, before we were taught that everything was about these rhythmic milking movements. And they're, of course, still a part of it. But we know now that it's actually the vacuum drop of the jaw and the tongue together that is making the intraoral negative pressure that is transferring the milk into the mouth. So if the baby doesn't have the ability to go the drop, not with sound, then we have a problem making the intraoral pressure removing enough milk. And that also relates to where can that baby put that mid-tongue. So I always test how far can I get that mid-tongue, how much of the mouth floor is lifting, and how is the muscular tension in the mouth floor and connecting muscles and the fascia is going all the way up to the temporals and all the way down in the body. So in the babies, I know the fascia goes all the way down to the feet, but in the young breastfeeding babies, I usually see them going to the diaphragm, or in some children, the hips. But usually, because they're not standing and walking yet, I do not see a lot of tension in the extremities, I must be honest to say. So I do think I do a lot of work around the thorax, the mid-back, the diaphragm, the whole facial opening, all the way up to the parts of hyoid cartilage that is not formed. I mean, we also have to, we need to work around the hyoid. And I'm like, yeah, but hyoid is still in like 6 pieces. So I mean, how actually more 5, 1, 2, 3, 4. Yeah, the corneal 5. Yeah. So I mean, so we still have like a lot of things floating around, and babies are much more fluid and much less strict and in the fascial lines of tension yet, because they're just getting to reinforce that. They came out of the body. Now they need to work against gravity to have these lines of impact stronger and stronger to form and shape and get us up standing. So I do think looking into the body is extremely important, because sometimes we forget that breastfeeding is a suck, swallow, breathe. So if I have a baby that is side bending and actually is not breathing very well, then I have to decide, do I want to suck or do I want to breathe? Yeah. So, I mean, a lot of babies with breastfeeding issues where everybody goes, oh, it's the tongue tie. I'm like, no, it's a breathing problem. It's dysphagia. It's the ability not to be able to swallow properly because you have tensions everywhere in your body. So I do think, because we have so many muscles, fascias, bony structure, let's call them bony, that are working together to make this process work, there is so much detective work we need to go into to see how can we balance, how can we manage, which part of the chain is not doing its work. So it's really detective work for me. I'm like, Sherlock Holmes, let's look into this body. Yeah.
This is so fun, Didde, talking to you about all this. It's great to have a chat about all this, because it's not something that I think we get to do enough, is really get in and think about these things and really talk them through. Like body work, really, for tongue ties, there's lots of us doing it here in Australia anyway, but of course not very much research. And a lot of the tongue tie providers over here do refer to osteopaths and do see the benefits that we can provide to their patients. But we're still in a situation where there's a whole bunch of health professionals here that don't believe in them. And, you know, we even here, where I live in Canberra, you know, we often get anecdotal, you know, parents telling us, oh, the pediatrician told me they don't exist and there's no reason to ever get one snipped. And, you know, yeah. What's it like in Denmark? Is it, now that you've had this consultation process,
actually
is it better?
Well, it's still problematic. But what the national guidelines actually came out with was that one of the only thing that they actually had okay evidence when they looked at was actually that snipping the tongue tie could have a good effect on breastfeeding. So all of this, it doesn't exist. Well, suddenly they were like, oh, damn, it does. And there's actually quite a lot of research on it. So, I mean, so they have to sort of like, yeah, it's there. Now they're more discussing, but is it so important? Do we really know if it's...
Is it overdiagnosed?
Exactly. And I do think that at one point it was. I mean, everybody was saying, oh, yeah, it's tongue tie. Oh, not for me. So I do think we're finding a better place now where we're more open to the diversity. And also because it's much more of a functional diagnosis now. We really can get in there and do something about it. So I do think it's been overdiagnosed. I do think that I never thought it was a fad. I mean, some people in Denmark, they said that I invented tongue tie, and I've had these very nice carvings from the 1600s. And I'm like, I'm old, but I'm not that old. So I wasn't a part of that at that time. So it's always been here. It's just, I think, because more moms wants to breastfeed, and I think because information are much more accessible, then suddenly it's a thing. where otherwise it would have been, mom to mom saying, I had this problem and you know what we did, and they would go, oh my God. So the information spreading would be so much slower than it is now. So I do think that all the social media is a good thing, because you can get aware of problems much sooner, but it's also a problem because people are now diagnosing other people's babies online, going, oh yeah, it's a tongue tie, I can see that. I mean, and that really makes me sad, because I do think it's much more complicated than just going, yeah, snip. And that's also why I see some people having their children cut, and they have amazing result. And I do have other people coming into the clinic saying, oh, you know what, we were diagnosed on the internet, we did the cut, but it didn't work, can you help? So it's sort of the wrong way around. If they come in and we did this first, maybe they didn't have to go to that phase where they needed to cut. So I think we're more agreeing on that it's actually there, because the research is actually there. But I also find it a bit saddening, because they're always saying, well, where's the evidence? Where is the evidence? And I'm sad to say, I don't think that evidence will ever come to be, because first of all, we have the whole ethics. So if we do think that cutting a tongue tie is actually beneficial for babies with tongue ties, we could not defend taking half of them and not doing the incision. Then we should have to do some kind of crossover. And we also know that some children, if they're cut too late after the reflex, the sucking reflex integrates, can be much more work to getting this baby to use the tongue as we would like it to, because they don't support themselves or lean up against that reflex anymore. So I do think, I do think that study will be hard to do, and who's going to make the money of it? And the research that is already out there is made primarily of people that is already doing the incision. So they will always be biased, because you're making money on this research. So if I did a big study, they would say, yeah, but you make money of this. And I would go, yeah, but who else would be interested in doing it? Nobody in their right mind, in, I don't know, economics, would go, oh, I think I might do a study on tongue tie. I mean, they wouldn't. So, I mean, we would always be biased. We would always have this, well, maybe the baby grew out of it, because we know developmental things happen as well. So yeah, he's better at breastfeeding, but was it because of the cut, or was it because he's just 1 week older? We cannot ask him, do you feel more free and mobile now? No, we'll just have to watch what is happening. So I do think that the research we're looking for is never going to come. And I think we will be, it's a donkey shot fighting against windmills to think, oh, we will have it in a few weeks. We will not, or months, or years, because I do not think it will ever come, I'm sad to say. But what I do think is that, I mean, everything starts with people being satisfied with what we work with. And if what I did with my hands did not have an effect, and that might be placebo, I am totally fine with being placebo. It's not a bad thing for me. If I work, yay, call me whatever, osteopath, placebo, I don't care, as long as they get better. And as long as I keep helping children to improve their breastfeeding, having moms that have successful breastfeeding with what I do, well, they sort of vote with their feet. And that's not statistics, but if they didn't come back or tell other people to go see me, I wouldn't be working with this. So I also think that the effect of the treatment speaks for itself, because otherwise we would be out of business.
Interesting. One of my friends here in Australia is doing her PhD on breastfeeding and tongue ties. She's a midwife, like IBCLC, and they do a pain scales chart on the mother before and after the tie release, and they're collecting a whole lot of data on a cohort of babies who are sent to their clinic. So yeah, you might be right. There's certainly some types of research that might be more useful than others. But yeah, it's a really interesting space, and it certainly could do with a lot more people putting some research together on it, couldn't it?
Yeah, and also those not new things you can put on your finger and put in the mouth of the baby to see if the pressure improves. Could be really interesting to see before and after treatment. Does this baby actually do a better sucking function now?
Yeah.
It could also be nice to do something with Geddes and see, is it
That would be
changing
cool.
the ultrasound videos of sucking after you treat it? I don't know, but it will still be a very small base of children. So I do think we will end up the same place. We might have 5, so it might be like a case study thing going on. I don't see the big studies being done with ultrasound and also the pressure. And also it's a different kind of sucking on a finger than on the breast, but yeah, what to do. Oh my God, you stalled again. I talk too much. Sorry.
We've lost her again.
Ah, you're back.
Oh, are you back?
Yay!
There you are.
You're back.
We're doing very
Yay!
well here. Between Australia and Denmark, we're doing well.
I think so.
One of the questions we had from our community was about your work with visceral osteopathy and children. In particular, any techniques that you use a lot for the sort of like 0 to 5 age group. Have you got any techniques you can quickly run over for us that you really love?
Yeah. Well, first of all, I would say I love doing visceral work. I do, and that's why I also did the Burrell. Burrell is French and did a lot of work on visceral and wrote a lot of books. He's a really brilliant man, and we also did visceral training in our studies when training to be an osteopath. So I always thought, oh, this is amazing. And the funny thing was, I did a course on visceral. And one thing we should do, because we really always tell ourselves we are so good at palpating. These hands are gold. So we were supposed to palpate a structure that we've been trained to find, and then they would ultrasound to see if we were there. And let's just say it wasn't amazing.
Okay.
So that made me a little more humble when doing visceral. So actually now, before I was like, yeah, now I'm working on the fascias around the liver, la, la, la. I never say that anymore. I say I work on the fascias in the area of the upper right quadrant. And I know what's in the upper right quadrant, and also taking into consideration that the baby's anatomy looks different than ours, much more compressed, not a lot of space. So going, yeah, now I'm on the colon. Nah, maybe not. And all of these winding of the ITs that are not there yet, and all of this. I mean, yeah, we just have to put it into a different perspective. So that being said, I am much more humble, or what can you call it? Not scared, but yeah, I don't know. When I tell people that I work on the fascias, I just say I work on the fascias, and the fascias will be connected to the neurology, the vascular system. So I'm trying to improve vascularity and the neurological input to that area by working on the fascias. So that's the way I go now. But one structure I love working on is the ligamentum teres. So the residue of the umbilical cord going going up into the fascia of the liver, I think is really, really interesting to work on, because I see tension in the line in young babies, especially with reflux, actually. But I also see it in the bigger children with that has a problem digesting or eliminating
like constipation or
constipation, but also babies with rash or children with rashes or sleep problems because they're not digesting very well, so they have like toxins going in second loops. I work a lot on this structure.
Right.
Yeah. And also I work a bit on the structures going the other way to our rachis, going to the bladder, because sometimes tension from there can also give a little bit of hyper facilitation of the bladder. So in the children that pees all the time and have a problem. So I'm really a belly button person. I get my finger in there, I work around. So in the viscera, I think working on the digestive system, so from here to anus, is very important for me, because I know how much the elimination process is affecting the baby's health. So getting rid of stool, getting a better absorption of nutrients, tolerating things better. So that's really a big issue for me. And especially in the young children, we're much more focused on the colon, where the ITs come in later. And also all of this connection around, gallbladder, pancreas, when they get to work, and people are like, oh my God, why don't we just give them porridge from their born? We're like, well, the pancreas is not really making that much digestion enzyme until they're 6 months and on to their 2 years. So it's not a good idea to put too much starch into them. So many things, I think, is amazing to know about the visceral system, and also to try and just support it by giving as much fluidity and as little restriction to that fascial tissue that is actually supporting, but also keeping everything mobile.
Yep, gotcha.
So, yeah.
Cool. You have a particular interest in birth trauma, and one of the questions I wanted to ask you was about those babies that come in who cry for extended periods. Sometimes we call it purple crying here, where they just cannot be settled.
Yeah.
What are the common things you see in a case history for a baby like that? What do you think to yourself? Oh, I bet this
Well,
baby's got
a lot of the purple babies, that's really nice. Blue babies crying themselves blue and white and purple. Actually, a lot of times I see they've been assisted birth. A lot of times they have been induced, and then they get the oxytocin injection, then they get the epidural. So I often see once you start off giving something, it sort of cascades, and they end up in vacuum extraction or C-section. So a lot of those babies that have very long, hard labor or are helped to the world is actually the induced babies. So I do think messing with nature when it's not ready to say, yeah, let's go, is actually just putting the bill to the baby, saying, yeah, you were supposed to be in there longer. You were supposed to work much better. So I do see babies that have had help just getting into the labor. I do see babies that have been extracted with vacuums, and also with Walton, it's called, I think, and also the babies with the C-section. But I also see babies that are either standing in the wrong position for a long time in mom's pelvis and not really working together with mom, because they're not getting an agreement on where to go and how to facilitate the labor. And also the babies that are born really quickly. So they are usually the ones, the induced ones, the helped ones, the ones that had long or very short birth. And one of my friends said, but what's left? I was like, well, I do have babies that have very nice birth, where every step of the way just goes as it should. So, and of course, I do see a lot more babies with problems. So my view is not, that this is how every baby looks, because they come to me when they have problems and not when they're just healthy and happy. And well, they can come for a baby check if they have bigger siblings, and usually they come in right from the delivery room, get them. Yeah, but otherwise it's usually because the babies have problems. They come to me.
Yeah. They feel interesting, don't they? Some of these kids, like they are kind of in shock. They have sort of like a real sympathetic shakiness, hyper alert, overactive moro, very unsettled, uncomfortable babies.
Cold hands and feet, clammy hands and feet.
Oh yeah, that's a good one. And so what do you do with these babies? How do you address that nervous system irritation?
Well, I actually do a lot of work on the visceral system. because I do think we need to look at the afferents, because a lot of us would go, oh, I need to work on the vagus nerve. But a lot of the babies have tension and irritation around the skull base and the neck. And of course, I will also address this, but actually I do it the other way around. So I actually start off with working on the pelvis, working on the viscera. So giving this nice bodily calming effect on the whole system. And then I work a lot on the diaphragm, because the breathing is so important for me. Giving the baby the best ability to breathe their way through this. And then I go to the skull base and the vagal nerve. And a lot of people say to me, but wouldn't it be smarter just starting up there, because it's related to everything else? And I'm like, yeah, it would. But if the baby is really sore and really irritating, and you know, those big eyes where they're like staring at you from across the room, then I need to some way get an agreement with this child that it's okay that I touch you. It's okay. And I mean, that's the funny thing. I have parents that come in and say, oh my God, you're the first person that speaks to my child. And I'm like, that's strange, because it's a person. So yeah, I'm a bit crazy, but I speak a lot to the child, and I tell them what I find, and I tell them how we work together to release it. And that also makes the parents shut up, because otherwise they're like, what did you find? Did you see that? Was he, I think he has, you know, they just sort of just stay there and just watch, because they know what I'm doing, because I'm telling the child. So I do work my way up into the war zone. But I also do think that using this afferents, working on the viscera, I mean, we have so much more afferents going over vagus nerve than efferents. So I'm like, I'm working on 80% of the vagus nerve instead of just the 20 going into the skull base. Yeah.
That is super cool. Because, you know, the babies I see like that, they really, you know, they are so unsettled that you can't just lie them on the table and put your hands on their head. They are going to scream the house down. So sitting them up, bouncing them, moving them, and working your way up to that, even over a treatment or two sometimes, like, you have to really take your time with those babies, don't you? You have to take it very gently and get that agreement, exactly what you were saying, where you can't just fly in and do whatever. They need you they need you to make that agreement with them, and they need to trust your hands. Otherwise, they're just going to get so upset with you, and that's no fun for anyone, is it?
No.
Yeah.
A lot of times I also work in the mouth.
Just tell me more about that.
Yeah, because when I get up to around neck, throat area, skull base, membranous skull, I sometimes just go into the mouth of the baby, you know, just having, I need to check it anyway, the palate, the jaw, whatever, tension in the cheeks, the lips, tongue, all of this. And when I'm in there, actually, I get babies to suck on my finger, and then it's much easier for me to work around their neck and their skull, because then they're sort of fixing the whole visceral skull. And I'm working on the neurological part, or the neurocranium. So, so I use a lot of this. I will give you something that's really nice, and then I sort of trade with something that can be a little irritating. So a lot of times I have like the finger working in the palate, and then I do a little work around the jaw, and they go, oh, I'm not happy about it. No, I know you're not happy. Let's do something else. And then, oh, let's go to the skull base. Oh, and they're like, oh, I don't really know, but oh, this is actually quite nice. That's fine. Okay. So, I mean, we do a little like trading. And usually I manage. But I mean, and otherwise I would just have to say to mom, well, now you go home and you do skin to skin, you do a lot of pressure massage, you do a lot of bringing baby into the midline, folding, all of this to sort of externally bring baby into a parasympathetic state. So instead of being out here in the sympathetic, we sort of go, and if you're breastfeeding, he's a little unsettled, try and see if you can just bend the leg a bit, just a little bit, just getting him into that flexion, just taking him out of this And,
Yes.
rolling to the side when bringing him up, being a little more slow in your movements, showing him that the world is a good place and he's landed with the most perfect family and you're going to see to every need he has. So, yeah. So
Oh,
I think a
beautiful.
lot of my treatment is also supporting the parents in being parents and, giving them that power back. Parent empowerment, I think, is 50% of what I do, is saying, your baby best, because when they come to me because the baby's been crying or whatnot, they have often had the feeling that they do not know how to manage this and they could not get help. And everybody goes, yeah, he will grow out of it. And they're like ready to throw the baby off the balcony. So I do think empowering them and saying, you know best. Your midwife might say, no, there's nothing wrong with him. But if he's crying 24 hours, well, then there is something. And you know your baby. So, of course, I listen to the parents and their concerns and saying, you know what? You know exactly what to do. And if this feels good for you, that's what you should do. So, yeah.
One of
Parent
my
empowerment.
colleagues, yeah, one of my colleagues, Betsy, described it as gaslighting when a
Yeah.
mother has a baby who is inconsolable and the GP says they're fine, they're gaining weight, they're developing normally, your babies just cry. And she's like, clearly there's something wrong. Why is it so difficult to just say we don't know? Or, there is obviously something wrong, but as far as we can tell, there's nothing that we can do about it, at least. And yeah, it's very frustrating.
Well, or just saying, well, it's not in my scope of practice.
Yeah.
Within what I know, there's nothing I can do. I cannot offer you any medication or operation that will help your baby get better fast. So it's not in my scope of practice, but I see you, I hear you. I can see that you're struggling, but I can reassure you that at least your baby is gaining weight. So one good thing is going on. I do think that we need to be much more aware of the nocebo and the placebo. I have an ENT that says to the parents, well, I cut his tongue tie now. Of course, he will not be a world champion of breastfeeding because he has that high palate. And I'm like, why are you saying that? I mean, who says he will not be the world champion of breastfeeding? And why do you need to be a world champion? And who knows what this release of the tongue will do to the palate on the mid-face growth. So I'm like, stop saying that. I know he's doing it to sort of say, yeah, it's okay if he's still losing a bit of vacuum because he has this high palate. I know that's what he's trying to say, but really thinking about how you're saying things, because it really weighs hard with the parents, because you're a professional. You really need to be aware of your rhetorics, that you use supportive language, that you listen, and that you emphasize the placebo more than the nocebo.
Yeah, that's
just like saying, oh my God, I've never seen a skull like that before. Oh, wow. And what a torticollis. Oh my God, I'm happy he can even breathe, I mean, and of course that can be a reassurance that the parents were not totally wrong, but it's not nice, And also, when we go through the babies and go, oh, there's a little tension here and a little tension there. And when we're done, the parents are like, is he totally off? No, he's fine. And they just hear all this, a little tension and a little, and suddenly they think that something's wrong with their baby. So I do think we also need to say, oh, I would so much love to give him a little bit more mobility to the left side, because you can see he's very good at moving to the right, but he also really, really would love to move to the left. So we're going to do some treatment over here to make it easier for him, and you're going to do exercises at home that would just support this journey on going to both sides. So thinking about how you present things, I really think that we can make a difference just in the words we choose.
One thing we've noticed is that the mums coming in are becoming a lot more anxious. Is that the case in your practice as well?
Yeah. And we do also see more people suffering from anxiety and depression that we saw earlier. Maybe it's just because we're speaking more about it, that it's more okay. than it was earlier on, that you just went home and so maybe it's just because we're better at vocalizing now if we have an issue with anxiety and so on. But I also think that the pressure from the media, being the perfect mom that, you know, can manage everything. I think, I mean, you know, the pictures from Instagram, and young moms look at that. They see these influential people going, oh, now I'm pregnant, and whoopee, here he is. And you're thinking, oh my God, what a lovely baby. And he's so beautiful. He sleeps all the time and la, la, la. And then they have this screaming mass of body going on, and they're almost deaf because nobody told them that it can be hard work getting to know this little person. And they only have one way of communicating, and that's by crying. So trying to figure out, why are you crying, getting to know each other, getting to be in this world of gravity and light and pressure. And I mean, it's just a big thing. And I think that's what we also need to convey to the moms. And also the thing about, you're doing a good job. Your baby's fine. I always end up by saying, well, of course not if the baby is totally, I suspect something is wrong. Well, I still say you have the most fantastic child, and I emphasize all the good things. Nice tone, nice muscle tension, fantastic movement, la la la. Because I really think that that is also a way to help them think, oh, okay, it was not that bad. So they can worry about something else. But I do think that there is a shift in in the anxiety and the pressure and all of the diagnosis of neurodiversity. And I think we need to be able to manage that as well, to manage how diverse we are as people. There's not one formula fits all, that as individual as the children are, the families are. And when we're a pediatric osteopath, we're always treating, well, the whole family. I'm treating the child, but we have like parents or grandparents or in the room as well. So, I mean, it's a totally different dynamic than just having one person on the bench going, yeah, let's have a look at that shoulder. So I do think that it's a much bigger thing to do and a much bigger responsibility.
Absolutely. That's a very good reminder to even things that we might think are a bit innocuous. But what you've just described is going beyond that, of not just watching what you say, but really letting people, creating a space where people feel really supported and leaving feeling reassured and confident. And yeah, that's such a precious thing, really. It doesn't happen enough for families with young babies. Yeah.
I had a mum coming in last week, and she said to me, you know what, Didde, we just talked about you in my mother's group. She's on an online mother's group. And she said, everybody that's seen you says, it's like getting a mental hug every time you're with her. And I was like, oh, I was so touched, because I was like,
I'm feeling that right now.
Yeah, exactly. It was like, oh, because I do think that's one of the problems. We're so isolated. Children used to be raised by a village, right? It takes a village to raise a child. And now you're sitting there in your flat, totally isolated, and not having a clue on what to expect or what to do about it. So I do think that listening, creating a safe space for all the questions that you know you have. I remember how it was being a young mom with my first child. I walked out of the maternity ward and I was like, are they just gonna let me go? I don't have a PhD in this. They don't, I have no clue what I'm doing. And the first days I was like, oh, this is a joke. They're gonna come and take him. They're going to come and say, of course you cannot have a child. You're 23. You know nothing about raising a child. I will take him away. But I mean, and sometimes I was also frustrated sitting there with a crying child, trying to breastfeed, trying to change the diaper, trying to do, all of this, and still not succeeding, calming him, and just felt like this big failure. And I was like, well, I'm sure I wasn't the only parent in the world feeling that. Being like, oh my God, why don't I know what to do? Why don't I know how to calm my own child? But I mean, just saying that, just embracing that we all have our moments of doubt, that we can all be vulnerable. I think it's really, really important to share, because we're sitting there as some kind of authorized person saying, well, this is how it's going to be. But showing that we have a personal, humane side as well, not bringing our own stories to the table, but just saying, I know how frustrating it can be sitting there as a new mom or new dad, wondering if you do everything right. And you do it really, really well. Everybody goes through these problems. It's not just everybody that tells about them. And I often thought, when can I call an adult? Yeah. When is the adult person coming?
Yeah.
And for just a brief moment, I can be that adult that says, well, you know what, you're doing well.
Yeah, it's so messed up, really. I don't know how we ended up in this situation where there's just all these people sitting in their houses with a baby on their own, you know. It's just no wonder there's an epidemic of, you know, anxiety and mental health issues and people not coping very well, because it's not how it's supposed to be. And it sounds like, you know, you've come to the conclusion that providing some kindness and some support to people is incredibly important, and it's a really good reminder for all of us, really, to make sure that's a big part of our practice.
Yeah. I mean, one of my mantras is, in a world where you can be anything, be kind.
Yeah. It should be on a t-shirt somewhere for sure.
It should. It should.
I've got so many more questions for you, but I probably shouldn't be too much longer. So I'll launch into basically tell me more about these courses that you're running in November in Melbourne.
Yeah. Well, I was so lucky that John, that has a company in Singapore, asked me to come and teach for him, and also Sarah in New Zealand. And happily, I'm not going to Singapore to teach, even though he told me to come. I am going to teach physically in Melbourne. And the first course we're going to do is the Pediatric anamnesis.
Now, this is a new word. I had never heard of this word, anamnesis. I had to look it up.
Yeah, what's that? Well, that's just the history taking of the baby. So it's the history taking. So it's going to have like blocks. It's going to have like the history taking. What things do we need to know when we ask parents, how was the birth? How was the la 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 la? Because it actually has an impact on what do I want to look for when I have the children in my hand. And also to see if there is any obvious red flags that I need to be aware of and check even further when I have the baby over. So there is this history taking with all the nice to have and good to have and must haves. And then we have the red flags. And the red flags is like the obvious pathology, but it's also the movement of the child. Is the movement of the child as it should be at that age? It's also the motoric milestones. So if you have a 3-month-old baby on your table, what would you expect to see? Because the brain would be developed at that stage. So you will need to see these things. Do you see them or don't you see them? And then there is the reflexes, the primary reflexes, that some of them needs to be there, some of them needs to integrate. So again, depending on the age of the child, what would you expect to see? Because that's all bits of the puzzle of being safe. So if I see a child with very funny, spontaneous movements, and they also miss a milestone, and I also see something with the reflexes, then it would be I need to have this baby checked by a pediatric neurologist, for example. Well, at least refer back. So I do think in babies, the safety is much more about knowing all of these blocks and putting them together. So if I have one reflex where I'm like, not too strong, then I will have it in mind. But if I don't see anything else, I would not be concerned. So that's quite a big block, and we will train the things, the milestones on our own body, because I do think sometimes when you've been lying in those positions, you remember them better. Going, oh yeah, I was 8 weeks old. That was when I was lying like this. What was happening in my body? Oh yeah, so when I have a baby in my clinic that is lying like this on the stomach, oh,
Yeah.
it might be a little residue of rotation to the right side, bending left. Oh my God. And then we have, I have tried and put together like what I call the medical and examinations, you know, the reflexes, the tone, the hips, all of these things that we need to do to be safe, and also put in the mechanical examination of the baby. Where do we need to look? What are we looking for? And I've tried to optimize it so I can actually do it in, I think, 3 or 4 minutes, really fast, checking everything through. And that's what we're going to practice as well on the dolls. Just to get it in the hands, because sometimes, you know, you're sitting, yeah, and I will do this and I will do that, but just having a practice, even though it's a doll, is actually quite nice, and we can do it really fast. So
yeah, awesome. Awesome.
So that's the first thing.
Yeah.
And the second one is the colic reflux one. So there we will go into a lot about the theory. What theories are behind reflux and colic? What do the medical world think about this? Because I do think it's a part of our knowledge to know what are everybody else thinking about this. And then we will look into the physiology and the physiopathology and try and dissect what can we do as manual practitioners. And I always give like, I have like pictures and techniques. So you have something you can take home. And we also do practice things. What I usually think is a big problem in pediatric courses is that you might have a 5-day course and you sit there and you work with your hands and la, 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 la. And I did that as well. And I came home to my clinic and I'm like, yeah, now I've been working on Peter's head for like 4 days, but it's totally different working on Emil's. Yeah, it's another anatomy. So I do think it's not that I say the time is wasted by doing practical things. I do think that it's nice to improve your skills, but it cannot be directly translated. So that's why I always put pediatric things in that you can work with. And then I actually do a lot of training of perception, of being fast, feeling what you're supposed to feel, because the window of treatment and examination is so brief in babies. So you don't have half an hour to go, oh yeah, I can feel it shifting, la, 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 la. I mean, you need to be speed dating. You need to go, boom, bang, ding, out. Yeah. So, I mean, so I actually use time on doing techniques just to feel it in your hands, even though it's totally off because we cannot transfer it directly, but also to improve our sensibility, our first impressions, the way we work with our hands. So I also have a practical part in there to sort of give like inspiration, of course. I take some of the, I mean, every treatment is unique, but I do take some of the methods that I use the most. So if I should look through my day, I would use these 4 techniques a lot compared to the rest.
Got it.
So that's what I'm gonna present, and also have a talk about, you know, all of this. What can we do? What kind of home exercises can we give to the parents? What kind of advice can we give to support the treatment that we offer? Because I do think, because it's such a multifunctional problem, both the colic and the reflux. I don't like the word colic. It's called excessively crying infant in my world. But I do think that we need to give something that the parents can do themselves. Again, empowering them, and also ensuring that the treatment I do is followed up by repetition of movement or repetition of strengthening or mobilizing, and also advice about how can we support this digestive system best? What can we take out? What can we put in to support this child to make a good balance in digestion?
I can't say I've come across exercises for reflux and excessive crying, like from abdominal pain. before. Can you give us a hint about what kind of things?
Yeah.
About?
Well, usually I have like, I call it the farting exercise. For the colicky babies, I have like 4 exercises I give the parents that are like a soft massage on the area of the sacrum and the transition between the pelvis and the lumbar spine to relax, and also to make a little bit of the, nervous system from the parasympathicus going to the lower part of the colon. And that's the first thing. Then I'm showing the parents a little stretching techniques of the fascias of the abdomen. So taking the whole compartment of the abdomen, sort of like a visceral sac release, to make space for everything going around. And then I do the mobilization, but also of the abdomen and pelvis together. And then we do a little technique on the stomach. You can do it when you're relaxing the stomach and moving holding the legs, or you can just do pressures on the stomach and releasing the legs, to just have this release in the fascias of the stomach. So that's something I usually give to parents to do at home. And they say, oh, you know what, Didde, when I do this and then do the squatting exercise afterward, he always farts, always fills the diaper. And for the reflux children, because there's so much in extension and so much in a lift of the chest, I really need that chest to go down to make the diaphragm a bigger influence in keeping the food down. So a lot of techniques for the parents to relax the thorax, and also because I see a lot of tension around mid-back, the TLO, the diaphragm. So holding this area mobile between treatments is really, really important to get a good effect on the reflux treatment as well. That's my experience anyway. And the parents really think that it helps also getting the burps up, and the baby is much more relaxed and happy when they do it. So I do have exercises that sort of bring the babies out of these reflexatory patterns of movement because they're in pain or irritation, or because they're hyperfiring to the vagal area. We don't know, but that's the theory anyway.
Yeah. Awesome.
So yeah, I have exercises to support them at home, or support the tensions we often find in the child.
That's really great, because I certainly, like, in a treatment, kind of getting a baby sort of nice and relaxed, but I hadn't actually thought of teaching the parents some, besides the usual like infant massage techniques, but that's a really good idea, to send them home with some more specific techniques to assist with those specific problems. Yeah. Cool. Thank you so much.
I mean, you cannot do anything wrong. You cannot hurt the baby by doing it. So I usually say, if your baby cries, then you stop, because you don't know if he's just not into it right now, or you might need a break, or so just if your baby cries, you stop. So I know they're not hurting anybody.
So are you going to spend any time before or after the courses in Australia traveling around and checking the place out?
I hope so, but I am going to be at the the convention that's down there in Sydney.
Yes.
Yeah, I'm going to attend that, and hopefully I'm going to Auckland to spread the word in New Zealand, and then back to Melbourne. So I have put some days in just to travel a bit when I'm down there. See wherever, Yep.
Oh, I mean,
I definitely need to see some of the animals. I definitely need those.
Yes, definitely. Well, I hope you have a wonderful trip while you're here. And thank you so much for your time this evening. I've enjoyed it thoroughly and learned heaps. So much appreciated. Thank you so much.
It's been a pleasure meeting you. I look forward to coming down under.
Thank you so much. Thank you.
Thank you.
Right. I'm just going to...